Dear friends and colleagues, it's really a pleasure to welcome you on the Edudent Dental Talk Show. You all know that we are going through very challenging times. And in order to keep our mood up and to stay in contact, to continue communicating about dentistry, a lot of organizations and colleagues and friends involved in teaching have organized webinars. I had the chance to be involved in some of those projects, and I asked myself whether it would make sense to be another voice on the net. And just to have a couple of webinars during this forced confinement wouldn't be maybe that meaningful and probably needed at all. On the contrary, I had the idea just to start now because, of course, we have more time to think about it and to put this together. But I had the idea to install actually a communication with you about different topics, concepts, clinical cases on a regular basis. Maybe something like once a month. And I'm really pleased to start today the very first of this dental talk show. And this specific one is going to be dedicated to toothware. I wish you an interesting listening to this program, and thank you once again to be with us today. So the idea here is to present the relative indications of preventive, interceptive, and restorative strategies to treat tooth wear. The first option, the one that we definitely want to favor in any situation, is the preventive approach. It can be to prevent attrition and abrasion by wearing a night guard, possibly a day guard, and for patients showing early signs of erosion, to correct their diet, what they drink, what they eat, possibly get the needed medical treatment to treat reflux or any type of therapy to help the patient to return to a more normal lifestyle. We see here a typical case of early signs of tooth wear, where we have here flattening of the incisal edges and the tip of the cusps on the lower incisors, and also some signs of tooth wear in the upper arch. Shall we wait until tissue destruction will increase? Certainly not. We see here 2018, so 24 years later, we have basically no major increase of wear, either on the lower front teeth or the upper front teeth. But a few wear facets here and there, but nothing really major. How could we maintain the situation, stabilize the situation over nearly 25 years of time? Here the secret is very simple. Patient has been fully compliant with having the night guard basically during sleep every day, nearly every day of his life. And we know that strategy is going to be fully effective. We cannot get this, unfortunately, done for every patient. Very severe tooth wear cases, patients having severe awake bruxism, would certainly need to wear a night guard also during or a day guard, which is more difficult, of course, to obtain in terms of compliance and cooperation from the patient. But it's always worthwhile to try and especially to inform the patients about the benefit of wearing the night guard. The second option approach is interceptive. Interceptive means partial restorations, usually with composite. We have different protocols: direct freehand, direct molded, single and multiple molding technique, and the shell technique which is actually a molding technique in the lab made from the wax up. We see here a typical case of interceptive therapy in a male patient of 38 years. You see that we have, significant tooth loss pretty much on all the upper and the lower teeth, but it's difficult to justify here to go straight to indirect restorations. First, because we might not be able to restore the case without some additional preparation, and also because the cost of the treatment is going to be relatively high. And I don't think that the severity of the pathology justifies such an approach. You see here the facial view of the case. You see also the typical cervical lesions, non-carious cervical lesions, which origin is probably a combination of abfraction, abrasion, and erosion. They are what we call hybrid lesions. We also have a flattening of the smile line, these being very often a reason for the patients to consult. And what we have done for this patient was to use a nearly no prep approach that has been set through a wax up. We like to get a functional anatomical reference to restore those cases, even if we use a direct freehand like we did here. These were not prepared, only clean with a sandblasting device. And we had some composite directly on the sandblasted surface after using a multifunctional adhesive. If we have small amalgams, we're going to replace the small amalgams at the same time. You see here after the application of surface colorants to get a more natural occlusal surface appearance. And here the final case with full mouth rehabilitation. No prep, everything with composite. The beauty of it is that it takes about 3 hours per arch to restore all the path of your teeth, normally including the canines and re-establishing the canine guidance. So that is a very simple, cost-effective solution to restore the missing volume, to re-establish a better anatomy and function. We see here 6 years later, unfortunately, the patients in this particular case has not been following our advices. It's a typical case of non-compliance. And despite the fact the patient didn't wear any night guard, didn't change his diet, unfortunately, we haven't got a major problem. Little additional areas of wear. Otherwise, most of the composite has remained. Maybe here also a little loss of tooth structure, maybe microfractures, what we call chipping of the composite. Some additional erosion or attrition, abrasion of the facial surfaces that we could fix by additional bonding. We are now in 2018. The only intervention between 16 and 18 has been to restore here the cervical facial lesions. We haven't done any other intervention on the patient's mouth. But now the time has come to do some refreshing, basically to add some more composite. You see here, to justify this intervention, the facial view showing that basically we have lost the composite which we had added some years ago. So it's time now to give a little bit of volume back to those cusps and to protect surfaces which were unfortunately involved in the tooth wear process. You see here the process of refreshing the existing restorations. Preparation involves, again, just sandblasting, and sandblasting will actually clean the surface, the dental surface, and the surface of the existing composite, so that we can then obtain proper adhesion with etching on enamel or dentin, if we choose to use a multi-step, three-step etch and rinse adhesive system, which we normally like, and also micro-retention at the level of the composite. So we use small amounts of composite, then we light cure, and basically this is the end of this interceptive. The interceptive concept works on a non-treated case as well as on a restored case. So the idea is that we don't need to take away the material, the restorative, the composite material, which we placed 8 years ago. The idea is that we can stabilize the case for another couple of years. With my experience, I've seen that we can easily maintain those cases over periods like 12 to 15 years before we need eventually to restore completely the case. That will take, of course, a little more time. The third and last option is restorative option. That's for more extensive and severe tooth wear and full coverage of the teeth, using normally indirect composite, especially for CAD/CAM technology, or high-strength monolithic ceramics, nowadays mainly lithium disilicate. The first case, patient who basically consulted because of the aesthetic impact of tooth wear. This is relatively obvious that here we have a flattening of the smile line. We have broken inside the ledges next to some discoloration, but that has nothing to do with the tooth wear. But we can understand that the patient has an aesthetic issue. Patient has a very prominent chin, is coming spontaneously on an edge-to-edge position, especially at work. He's a surgeon, and is totally aware of the fact that he's having a wake and sleep bruxism. His wish here is to get restorations which will limit the risk of failures, especially when discussing the option composite versus ceramics. The patient was made aware of the risk for chipping if he's having some awake parafunctions and that he doesn't wear any protection. So that's why we finally decided to use ceramics to restore some of the teeth, as you will see. Here is the view of the posterior dentition. We don't have any major tooth wear on the upper teeth. They're pretty much intact. The problem is again mainly on the upper palatal areas. On the lower, we also see signs of tooth wear on the front teeth, tips of the premolars, flattening of the anatomy of lower molars. The treatment plan here is to increase the video, to use as much as possible a minimally invasive approach. It won't be no prep like interceptive, but minimally invasive. You see here the pre-treatment wax-up. It's a simplified wax-up aiming to give us the new video and the basic functional and aesthetic parameters. We'll need to re-wax the case at the time we fabricate the pressed ceramic restorations. So that's why it was considered useless to invest more time in this pre-treatment wax-up. You see now the final restorations. They are Emax press restorations, overlays for some restorations, veneerlays for some others. You see that here restorations are going all the way to the cervical, where we had either a problem of alignment and also some facial wear. Those restorations are stained and glazed. We don't want here to use any veneering, with a weaker porcelain. We use the exact same material for the upper 4 incisors. They are stained and glazed restorations. Of course, they don't have the very high aesthetics, which we can achieve with veneered restorations. But here we had relatively thin restorations, so we'll give priority to strengths, of course. You see now the lower arch completed with the overlays. And what I will demonstrate now is the next step with the lower incisors. Lower incisors were restored with the shell technique. The shell technique makes use of composite, a flowable composite, which will create a very, very thin layer. It's nearly like a matrix somehow, and that will not have any negative impact on the strength of the restorations. We know that flowable materials are maybe not mechanically as strong as a restorative material, but they serve only as a support to apply the next layer. Next layer will be dentine. The dentine comes a little bit further on the enamel, the worn enamel, so that we will have a smooth optical transition from the composite to the tooth structure. And you see the final situation after completing the restoration of the lower arch. So we have composite, canine to canine, and ceramics further back, premolars and molars, to stabilize the vertical dimension of occlusion. Nothing was done on the arch. Now you see the whole arch with a proper anatomical alignment of the teeth, and also a much better occlusal scheme. Upper front teeth were restored, as you know, with lithium disilicate restoration, stained and glazed, no veneering here. Canines and canines were restored with composite, with direct composite, and we've done a few additional direct bonding on the lateral teeth, but no indirect restorations, no major buildup on the other back teeth. You see the situation 1 year later. Of course, we don't expect any change to happen over a 1 year period, but I would like you just to make or observe the lack of significant wear on the canines. Of course, nothing on the lithium disilicate material. Lower front teeth, we have some minor wear facets, which we would expect in such a case. Patient is still aware of his daily or awake parafunctions, but you see that the composite is just wearing off gently, very, very rarely chipping in the lower front teeth, because the composite works mainly in compression. And composite is a good material to resist compressive forces in general. So very, very limited risk for chipping on the lower front teeth. You see the final situation with the full occlusal views for upper and lower arches after a little bit more than a year time. It's closely to 1.5 years, and no major problem, as of course we expect. I will finish this overview of the various treatment strategies with a last case, a bulimic case, but a patient also suffering from bruxism. Patients suffering from bulimia or anorexia are patients unfortunately under psychological stress or distress. And it is very unlikely that those patients will have no parafunctions. So you always need to look for signs of attrition in those cases. That is a situation in 2006. We had identified already some problems, some teeth which had a more severe mechanical breakdown and biomechanical breakdown, but here we were still facing mainly a problem of erosion, attrition, most probably, but it was maybe not so obvious, maybe a few decays as well. You see now the same patient 10 years later. Nothing was done over this 10 years period due to the fact that after providing a second opinion, which was confirming the recommendation of my colleague, namely that the patient will require a full mouth rehabilitation, and because the patient could not afford the cost of the treatment, nothing was done. And you see now the dramatic evolution of the pathology. You see that a couple of these are basically irrational to treat, to use the modern terminology. Upper first molar, lower first molar, even the second lower left molar couldn't be treated. The endodontic infection went on for several years, and we had basically a perforation of the furcation. We tried, but after a couple of months, we had to extract the tooth, as we did for basically wisdom teeth. It was not really meaningful to keep those teeth in place. You see now toward the end of the treatment, you see the amount of work that had to be done. Parental work, extractions, implant placement, reconstruction of the bases, stabilizing the remaining tooth structure, going with protective preparations. Protective means to cover most of the tooth structure to prevent relapse or further tissue destruction because of acids and you see here the upper arch, exact same approach. One implant on the upper right side, as you have seen from the previous radiograph. But what I want to show with those slides is that the amount of preparation work is relatively important. Of course, now it seems to be straightforward, but you can imagine that going from the initial situation to that situation has required a lot of time and efforts, and that is having a cost. The only 40s where I could fortunately maintain a highly conservative approach was again for the lower incisors, where there is no imperative need to go with ceramics and additional preparation. So those are partial direct restorations, again, taking advantage of the fact that those restorations are mainly submitted to functional forces, compressive functional forces, which limit the risk of failures, mechanical failures, apart from a little bit of wear. You see for the upper fronties, the amount of length change that could be achieved with indirect restorations. Those restorations were basically entirely into enamel, so they are like 360 degrees veneers, which is very convenient. That provides good stability for the adhesion and minimizes, of course, the biomechanical impact on the residual tooth structure. We used again stained and glazed Emax press restorations. Well, at this magnification, we see that the stains maybe sometimes do not look as good as translucent, apopescent veneering material. But again, here, the key word is making the restorations as strong as possible. And I must here thank Serge Erpen, our master dental technician from Oral Pro in Geneva, for the wonderful work. This is the final situation. These are relatively squarish because the patient has a really squarish morphotype. So that was the tooth forms which fitted best the face and the smile of the patient. Some other views. And now in black and white, the amount of dentistry that we had to realize in order to save the teeth of the patient. As you see, the majority, not all of them, but quite a number of teeth had to be root canal filled, not by us. Even the posts were already in place for some of them. And we used only titanium posts on a few places where we had basically to give some extra retention to the restorative material. Even though I'm personally not a big fan of post in general, for me, it's no post, no crown dentistry, as Pascal Magnier has so nicely put together as basically as a philosophy for severely biomechanically involved teeth. And the last views of the case. I would like just to finish this talk with a couple of considerations. First, in regard to what is common to very severe tooth wear conditions, and something which is truly disturbing. It is because very often the dental team has failed to install the right pathology management. We have think different. We need to give more impact on preventive strategies. We need to intervene as early as possible when we observe any sign of tooth wear. Interceptive, in case we can't take action early enough. Interceptive treatment is the next step to engage. Restorative solutions, we have them. We need to apply them if we failed with the first two options. But the number of cases where we have to install restorative strategy should be the minimum number. We should be able, with proper preventive and interceptive strategies, to help the patients early enough so that he will not need full mouth rehabilitation. So please delay or even avoid restorative solutions at the beginning of tooth wear process. So we shall use more often no prep, composite protocols, and much less ceramics. Because if we intervene early enough, there is no need for ceramics in the majority of cases. Final consideration, tooth wear treatment is not so much a matter of material, but mainly of proper timing, risk factor management, and biomechanics. I want to thank you so very much for your kind attention. I hope the presentation was of interest for you. I hope that that has given you a proper understanding about my philosophy on tooth wear. And again, let's try to be preventive, possibly interceptive, and as little as possible restorative. It was a pleasure talking to you today, and I look forward to see you again for the next dental talk. Bye-bye.